Welcome to This Week in Health IT. It's Tuesday News Day, where we look at the news which will impact health IT. Today, the White House asks hospitals to bypass the CDC. Information blocking clock is ticking, and Seema Verma outlines early impact of telehealth on CMS or for CMS. My name is Bill Russell, healthcare CIO coach, creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. Now we are exiting the series, and Sirius has stepped up to be a weekly sponsor of the show through the end of the year. Special thanks to Sirius for supporting the show's efforts during the crisis. Don't forget, we've gone to 3 shows a week now. Tuesday, we cover the news, Tuesday News Day, that's today. And we have interviews with industry influencers on Wednesday and Friday. Also of note, I am going to be taking a week off. I'm taking my own advice and finally taking a week off. We've produced a ton of shows since the 1st of January. We're just going to take 1 week off, catch our breath the last week of July, and then the next week. Whatever next week is, that's the week we're taking off. So you're going to have a week to catch up on some shows and those kind of things, and then we'll come back the following week and get going into our fall schedule and fall interviews, which we are getting lined up even now as we speak. I'm going to keep saying thank you. We've eclipsed 100,000 downloads of the podcast through the first 6 months of the year. Thanks for sharing it with your peers, and thanks for listening. To make it easier to share with your peers, we launched Clip Notes. Clip Notes is a subscription that gets you an email for every episode we record that has a summary, has bullet points with timestamps of where the key points happened in the show, and 1 to 4 short clips from the show. You gave me the idea, actually. You asked me to make it easier for you to share the best thinking with your staff from the show, and that's what we've done. That's what Clip Notes is for. To subscribe, you can hit the website and choose any show, and we'll have a link to subscribe to Clip Notes. But we also have a really easy way to subscribe. Send an email to clipnotes@thisweekinhealthit.com, and you're going to receive a link to subscribe right now. So go ahead, subscribe right now. Start getting insights that you can share with your team. Last thing, if you haven't signed up for 3X Directs yet, you're missing out. Text Directs, DREX, to 484848 and receive 3 texts every week with the stories that will help you to stay current. It helps me prepare for the show, and this is a service of Directs Ford, a frequent contributor of the show. All right, let's get to the news. So Twitter went crazy last week over the first story that we're going to cover, and let's see what, essentially, I have 4 different stories that I'm looking at here, but they're all the same thing. White House to hospitals, bypass CDC, report COVID-19 data directly to HHS. Okay, so I'm looking at healthcare IT news. I'm also looking at a handful of other sites because obviously something that's this politically charged, I wanted to see the different sources. We've also gone to the source. We have information from the HHS website, also looking at the American Hospital Association's, their announcement that they sent out to their hospitals as well. So that's going to be the primary source that we're pulling from, is the AHA's bulletin that they sent out to hospitals. So let's take a closer look and see if all this craziness on Twitter is warranted. So what did they do? The Department of Health and Human Services today announced significant changes to the process for hospitals to fulfill the agency's request for daily reporting on bed capacity, utilization, personal protective equipment, PPE, and in-house laboratory testing data. The most significant changes are detailed below. Reporting options: the Centers for Disease Control and Prevention, CDC, National Health Safety Network, and HSN COVID-19 module will no longer be an option for daily reporting as of July 15th. Hospitals are asked to use one of the other reporting options to fulfill the data reporting requests, including, number 1, reporting data to their state health departments, provided that the states have assumed responsibility for reporting hospital data to HHS. Or number 2, report to the HHS teletracking portal, an existing option for daily reporting. Okay, so those are the 2 options for reporting. If you have states like Oregon has put something together, Arizona has put something together where they are collecting this kind of information at the state level, I would assume, I don't know this for a fact, but I would assume that those states that are collecting that for state response are able to report that in then to HHS. So the data fields, HHS has made significant updates to the data fields it is asking for in daily reporting. All right, so let's just go to the HHS document, see what kind of fields, what kind of data they're looking for. So I'm looking at a document straight from the HHS website, which outlines this in detail. Here are some of the fields they're looking for. Hospital information, the usual, right? Hospital name, CCN, state, county, zip, you got it. The second thing they're looking for is all hospital beds. Third, all hospital inpatient beds. All hospital inpatient beds that are occupied, ICU beds, ICU bed occupancy, total mechanical ventilators in use, total hospitalized adults suspected of confirmed positive COVID patients. They also have subsets of some of these things. I'm going to bypass those. Total hospitalized pediatric suspected confirmed positive COVID patients, hospitalized and ventilated COVID patients, total ICU adult suspected of confirmed positive COVID patients, hospital onset, ED overflow, ED overflow and ventilated, previous day's deaths, previous day's adult admissions, that's number 17, 18, previous day's pediatric COVID-19 admissions, previous day's total ED visits, previous day's total COVID-19 related ED visits, previous day's remdesivir. I don't know why I have trouble saying that word, but I do. So current inventory of remdesivir, critical staffing shortages today, critical staffing shortages anticipated within a week, staffing shortage details. Are your PPE supply items managed? On-hand supply of individual units, duration in days. Are you able to attain these items? Yes or no? And they have a listing of items. If yes to the above, are you able to maintain at least 3 days supply? And number 31, does your facility use reusable, launderable isolation gowns? 32, indicate any specific or critical medical supplies or medication shortages for which you are currently experiencing or anticipating experiencing in the next 3 days. Okay, so those are the 32 items they're trying to collect. Nothing crazy here, nothing, this is what they need in order to put together a response to what's going on in each state as they surge, determining where they allocate resources, right? Makes sense. The AHA strongly urges, so I'm going on in the AHA, I'm going back to the AHA bulletin that they sent out. The AHA strongly urges all hospitals to review the announcement and report the data to HHS as requested. HHS stressed in the announcement the importance of reporting the requested data on a daily basis to inform the administration's ongoing response to the pandemic, including the allocation of supplies, treatments, and other resources. In addition, the agency notes it will no longer ask for one-time requests for data to aid in the distribution of remdesivir and any other treatments or supplies. Okay, so that's the end of that bulletin. That's essentially what's happened, right? So we were directing all that information to the CDC. Now we're directing it to the HHS. Why is that a big deal? Because the CDC data essentially is an open database that's available to researchers and everybody else. HHS is not as open. So that's the big catch here. So what's the so what on this? First of all, I think we have to talk about the CDC for a moment before we go into this. The first is, the CDC really had egg on their face from the get-go in the pandemic, right? So the COVID testing fiasco early on in the process came out of the CDC, and so they started behind the 8 ball. The other thing is the CDC pandemic preparation from a technology perspective has been a topic on the show. They're asking for, in the beginning, they were asking for too much irrelevant information, and then their practices are still kind of antiquated, right? So there's still information going into the CDC via fax, via mail, not email, via mail, like stamp and, that whole thing. So they're still using that kind of thing as a way to collect. It's not outside the realm of possibility that the CDC is technology challenged and not able to produce the reports and information that are needed to effectively coordinate a response. Yeah, right. So that's not outside the realm of possibility. It's also not outside the realm of possibility that this administration would like to control the narrative, and the CDC and the data sources do not allow for that. So here's the thing. Is it a political move? Probably, but it is most likely not only a political move. It is probably also rooted in less than timely reporting, missing bad data, poor compliance on gathering the information. It's likely connected to the CDC's capabilities, the CDC's modernization of their platforms, their technology, their methods, their practices. It's probably rooted in both. Am I trying to straddle the line? Probably. But if I've learned anything from being in the room where decisions get made, they're rarely as simple and linear as they get interpreted by the public. So yes, is it political? Yes. Is it technology-based? Probably. So the two are probably correct. It's not one or the other. That's how I'm viewing this. And at the end of the day, hey, I always ask myself on these political topics, if an administration that I was for made this request, would I be for this? And if the answer is yes, I don't care which administration's in. From a technology, from a pragmatic standpoint, from a coordinating the response in the local markets, and even potentially controlling the narrative, I'm okay with that. If it allows for a more coordinated effort, a better controlled effort in order to bring about the best outcomes, I can be convinced to go in that direction. So if my administration, whichever one that is in power, and they would make this request, how would I respond? And if I say, yeah, I'd be okay with this, then if the other administration's in power that I may not agree with how they're going to use the data or whatever, then I just, I have to coach myself to say, this is just the way it is. All right, let's move off from this story. Again, a lot of craziness on Twitter about that one. Of course, there's always craziness out on Twitter, so we'll just move on from there. The next story, early impact of CMS expansion of Medicare telehealth during COVID-19. This is a Health Affairs blog article. Seema Verma weighs in. I always really enjoy reading Seema Verma's stuff. And she had a lot of good things to say about telehealth. As you know, she has been a strong proponent of the expansion of telemedicine even before COVID-19. And now since COVID-19, she has really championed the allowances that have made the expansion of telemedicine possible. So let's go into this article a little bit. Again, it's healthaffairs.org. And I think if you just search that site under Seema Verma, you'll find this article. It is entitled Early Impact of CMS Expansion of Medicine Telehealth During COVID-19. All right, so during the coronavirus pandemic, the Centers of CMS has taken unprecedented action to expand telehealth to Medicare beneficiaries. Since people were advised to stay at home and reduce the risk of exposure to COVID-19, there was an urgency to increase access to telehealth. We've covered that a lot on the show. Today, we're going to share the highlights, and they're just going to go through it. So telemedicine, which includes telehealth and other virtual services, allows patients to visit with clinicians remotely using virtual technology. Innovative uses of this kind of technology in the provision of healthcare are increasing with advances in telehealth platforms and remote patient monitoring technology, right? So anytime we talk about telehealth, I want people to continue to expand your thinking of what telehealth is. It's not just that initial visit, it's follow-up visits, it's remote patient monitoring, it's IoT devices. This thing has a lot of legs and a lot of future, right? So she goes on to talk about March 13th, 2020, President Trump made an emergency declaration under the Stafford Act. With that, CMS began issuing waivers to Medicare programs, requirements to support healthcare providers and patients during the pandemic. One of the first actions CMS took under that authority was to expand Medicare telehealth on March 17th, 2020. All right. So CMS actions to expand telemedicine before COVID-19. By law, Medicare can only pay for most telehealth services in limited circumstances: when the person receiving the services is in a designated rural area and when they leave their home and go to a clinic, hospital, or certain other types of medical facilities for telehealth services. A telehealth service must use an interactive audio and video telecommunication system that permits real-time communication between the distant site practitioner who's remotely furnishing the service, such as a physician, nurse practitioner, or physician assistant, and the patient at a local medical facility. Okay? So the Trump administration recognized the value of telemedicine for patients and healthcare providers long before the pandemic. As part of that, CMS fostering innovative strategies, so forth and so on. You get they are heading in that direction, have been. In 2019, Medicare started paying for brief communications or virtual check-ins, which are different from traditional Medicare telehealth visits, as they are brief patient-initiated communications with healthcare practitioner. Okay, so they did that. And starting in 2020, Medicare separately has paid clinicians for e-visits, which are non-face-to-face patient-initiated communications through online patient portal. So they have been pushing this slowly. They have been pushing this. Okay, so COVID-19 hits. CMS efforts to expand telehealth prior to COVID-19 public health emergency serves as a strong foundation, which is true. CMS temporarily expanded the types of healthcare providers that can offer telehealth to broaden patient access across the board. All right, so they increase the number of codes that can be used. They increase the number of people that could actually deliver this care. They have allowances for the locations that can originate these services. Obviously, some of these physicians were not in hospitals. They were in their homes. So they did an awful lot of things. So what did we see? We saw an unprecedented increase in telemedicine. Let me give you some numbers. Before the public health emergency, approximately 13,000 beneficiaries in fee-for-service Medicare received telemedicine in a week. In the last week of April, nearly 1.7 million beneficiaries received telehealth services. Let me give you those numbers again. 13,000, 1.7 million. All right. In total, over 9 million beneficiaries have received a telehealth service during the public health emergency mid-March through mid-June. Specifically, data points presented in this section of the post are from internal CMS analysis of Medicare fee-for-service claims data through March 17th through June 13th. Okay. According to Medicare fee-for-service claims data, beneficiaries, regardless of whether they live in rural or urban areas, are seeking care during the pandemic through telemedicine services. In rural areas, 22% of beneficiaries used telehealth services, and 30% of beneficiaries in urban areas did so also. All right. So, and that's the biggest change, right? Urban areas is the biggest change. We already had a fair amount of telehealth capabilities and ability to pay for it in remote rural areas, but now we opened it up in the cities in order to protect, safety, right? For safety reasons is why we did this. Let's see. She goes into a little bit more of a breakdown. I'm not sure I need to go into it. 30% are female beneficiaries, 25% are male beneficiaries. It's across all age groups. 25 to 34% of beneficiaries have received a telemedicine service, 34% among beneficiaries below the age of 65, 25 among beneficiaries between the age of 65 and 74, 29%, 75 to 84, and 28% older than 85. So that's an interesting split. She goes into more of the split in terms of demographics: Asians, Blacks, Hispanics, whites, 30% Asians, 34% of Blacks, 33% of Hispanics, 35% of whites, 31% among others. And these are among dually eligible beneficiaries. There are no significant differences across race or ethnicity of those seeking telemedicine, which is really interesting. Evaluation and management visits. Anyway, she goes into a lot of detail in this story. It's probably worth it. If you are in the middle of trying to make the case for telemedicine in your health system, there's a lot of data in here. We should be collecting claims data. We should be collecting internal data. We should be collecting satisfaction data with our providers. Any kind of data that you can get your hands on, we should be collecting so that we can make the case for this to become permanent. Okay, so looking ahead, telehealth will never replace the gold standard of in-person care. All right, so that needs to be just driven home. I'm sort of doing the so what as I go through this story. That needs to be driven home, right? We are not trying to replace in-person care. We're trying to put in place telemedicine and place remote patient monitoring and those kind of things in key places along that care journey, along that care continuum, so that we can provide more efficient, better care, more personalized care all throughout the process, right? So if we're only talking to them 1, 2, 3 times, a month, now we have more data points. If we have remote patient monitoring, we're collecting more information. If they're able to just routinely have a weekly, video visit of 10 minutes to touch base with a physician assistant or a nurse practitioner, or even the physician, or even a care team, as we're going to talk about in some shows coming up. This is an opportunity to really change the model of care to have more of a care team approach to caring for the individual, because we can bring more providers in contact with each individual patient. All right. So, however, telehealth serves as an additional access point for patients. She goes on to talk about that. The data has shown that telehealth can be an important source of care across the country, not just for those living in the rural areas. I think we've seen that it can and will be adopted in urban areas. In fact, I would say it's probably going to see a bigger uptake in urban areas, especially now after the pandemic, or as the pandemic continues, I should say, not after the pandemic. So she goes on to say, Medicare spending and impact on the healthcare delivery system itself. First, it's important to assess whether the mode of telehealth service delivery is clinically appropriate. So these are some of the things that CMS is reviewing right now to see if the temporary changes should be made, the flexibilities should be made permanent, right? So first, they're going to assess whether the mode of telehealth service delivery is clinically appropriate, right? So we're searching out, is it appropriate? Is it the best use of funds and resources? Are we actually driving better care through the use of telehealth? They're also looking for fraud, obviously. The second is we need to assess Medicare payment rates for telehealth services. During the public health emergency, Medicare paid the same rate for telehealth visits as it would have paid for an in-person visit, given the unique circumstances. Outside of the pandemic, by law, Medicare usually pays for telehealth services at rates similar to what professionals are paid in the hospital setting for similar services. Further analysis could be done to determine the levels of resources involved in telehealth visits outside of the public health emergency, right? So what they're looking at is, does it require, will they do research to determine how much resources actually needed to do a telehealth visit? And finally, it is vital that beneficiaries and taxpayer dollars are protected from unscrupulous actors as more healthcare providers use telehealth to treat beneficiaries. CMS is examining our data for many of these angles, right? So they're looking for fraud, as we talked about earlier. There's that CMS database that's out on the Wall Street Journal website. And if you actually go into that, it is just amazing. You look at, you could, to the untrained eye, I will caveat this by saying, by the untrained eye, it would appear to me that there are some doctors that have figured out how to really work Medicare and where they can really maximize their revenue. I'm not calling it fraud, but they're maximizing their revenue by recommending certain procedures that can be done over and over again and still get paid. And you're seeing some Medicare-only doctors making $5, $6, $7, $8 million a year doing these procedures. Again, I don't know if it's fraud, but to the untrained eye, you look at that and you're going, that seems very interesting to me. And I think that same data does exist. I think CMS has the ability to really look closely at that to determine the best place for it to go. So what's my so what on telehealth at this point? I believe this stuff is going to be made permanent. I don't think there's anything to worry about. I would be making plans on where you are going to insert telehealth across the board. How do you coalesce that, the advances that we've seen during COVID? How do you find your champions and really keep it moving internally? I would not worry about the funding for telehealth. I think it's going to be there. I think if you wait to really bring it all together, first of all, you're going to lose the momentum. The second thing is you will be behind the eight ball because this is going through. You should assume it's going through. You should plan for it going through. You should plan for it being funded, maybe not at 100%, but you should plan on it being funded and you should figure out where it's going to go. What do you have to do for your platform? What do you have to do for your training? What do you have to do for compensation and other things? All those things should be on the table and the conversation should be underway. So those are just the first two stories. That's an awful lot going on. I'm already at 24 minutes. I'm going to keep going though. Oh, well, let's do this one. Health Catalyst announced agreement to acquire HealthFinch. Health Catalyst, who is a sponsor of the show, just getting that out there. Let's pull up that story. So this is, HealthFinch does clinical workflow optimization. Health Catalyst is doing a lot of population and health stuff. And so Health Catalyst has I don't know if it's called a division or what it's called, but they have a focus on clinical insights delivered directly within the EHR. And that's where HealthFinch is going to come into play. So you take a very powerful data analytics operating system and you take the ability to put those things and actually inform clinical workflow. I think this is the so what on this is I think it's a phenomenal acquisition for Health Catalyst. They need those capabilities anyway. I think it strengthens their approach to the market and only moves them, further down the road in terms of making those insights and analytics actionable in the care continuum. So if you're a Health Catalyst client, I would hit them up, figure out what HealthFinch is doing and where that can be integrated into your model. I think it's a pretty good thing. The final ONC final rule, compliance clock is ticking. I might come back to that story. Let's hit the future of remote work according to startups. Again, one of my favorite things, as you have heard, is these visual capitalist graphics, infographics that I've been getting. I now get the daily infographic. And, these guys are great. They're just artists. They take a question, and this one happens to be about around the future of remote work according to startups. And they talk about, they're specifically looking at startups. I think some of this is applicable to healthcare providers and those kind of things. I've seen a couple of these now, which just talks about, essentially how long it takes for people to feel comfortable working from home, 1 to 3 months, 3 to 6 months, 6 to 12 months, or never. One of those options. How many weekdays would you choose to work remotely? It's interesting because, well, actually, let me give you the previous one. 31% says they can get comfortable working remotely in the first 3 months. The 34%, it gets added in 3 to 6 month time frame. So if you work from home for 3 to 6 months, better than 66% of those people will start to feel comfortable. 21% gets added to that after 6 to 12 months. All right. So by that point, you have 80 some odd percent of your people feeling comfortable working from home. Just something to consider. How many weekdays would you choose to work remotely? These are the kind of questions you should be asking your staff, by the way, as we try to determine what the new normal is. Is it 1 day? Is it 2 days? Is it 3 days? I don't think it's 0 days. I don't think 0 days is going to work, but we've got to explore how much of this work can be done remotely, at least for the foreseeable future. How and where would you like to work? And what's the balance? Let's see, 81% would like a balance of office and remote. Only 10% want remote full-time. Only 10% want office full-time. Interesting, right? If you want the perfect bell curve, there it is. 10% full-time into the office, 10% remote full-time, 81% office and remote balance. So I think that's what we're going to be looking at post-COVID. And we're going to have some conversations about that in the fall. It's one of the topics I've given to potential guests to have a conversation around. How productive are you with remote work? I think is also pretty interesting. How productive during COVID-19, 23% say they're considerably more, 32% say slightly more. All right, so 54% of people say they're more productive. 17% say no change. Only 22% say slightly less, and 5% say considerably less productive. Okay, which would correspond to the number of people that really want to, be at home or be out of the office full time. All right, work hours during COVID-19. I think this is interesting either. 55% say they are working more hours than normal. And that's the thing that's hard for us to get our arms around, is that it's hard. I've worked out of my home actually most of my career, if I thought about it, and either on the road or out of my home. And it takes a certain amount of discipline to not work, right? Because the computer's there, your office is there, the mobile phone is there, the alerts, you don't turn them off at 5 o'clock. They just continue to pop up. It's really easy to start scheduling meetings earlier in the morning. So 55% are struggling with that. Quite frankly, they're working more hours than normal. Again, pretty good graphic, remote work, the good and the bad. They talk about, the worst part about remote work is less spontaneous connection with your peers. And that's the thing we have to think through as we have people work from home. How do we facilitate those chance meetings, those chance conversations that lead to new ideas and new thinking, right? The best part, no commute, flexibility, more family, lifetime. What do you miss? Social interactions, face-to-face collaboration, work-life separation. All right. So, hey, this is worth pulling up. Visualcapitalist.com, the future of remote work according to startups. And all those words have hyphens in between them, but you can hit that. That is worth taking a look at. And information blocking, to block or not to block, is a good article. I'm going to come back to that in the next show. I hope to. That is a story Dr. Craig Joseph gives that on. He's the chief medical officer for Nordic, and he gives a rundown. It's a good story. I don't want to shortchange that, and we're going to come back to that. Remind me, if I don't, send me an email and say you want me to cover that story. And then we are going to talk, next time we get together, we'll talk about the ONC final rule. Compliance clock is ticking, and it is ticking. And I'm going to start covering that in much more detail as we head into the fall, because I think a lot of us have been focused in on some other things, rightfully so. And now we are really starting to get our backs up against the wall in terms of the compliance around information blocking and other things. And we have to get our work lined up and get those things ready as that becomes the law of the land. That's all for this week. Don't forget to sign up for Clip Notes, send an email, hit the website. We want to make you and your system more productive. Best way we can do that is making the insights easier for you to consume, easier for you to share. Special thanks to our sponsors, VMware, Cerberus Advisors, Galen Healthcare, Health Lyrics, Sirius Healthcare, ProTalent Advisors for choosing to invest in developing the next generation of health leaders. We also are going to be adding 2 more channel sponsors in August. So if you are interested in sponsoring the show and to forwarding our efforts, please feel free to reach out. Bill at thisweekinhealthit.com. This show is a production of This Week in Health IT. For more great content, you can check out our website at thisweekhealth.com or the YouTube channel. If you want to support the show, the best way to do that is to share it with a peer, send an email, and let them know that you value the show and you're getting a lot out of it. Please check back every Tuesday, Newsday, Wednesday, and Friday as we will continue to produce shows for you. But remember, I'm off next week. I'm taking a break. I'll see if I can find a guest host for the week, but if I don't, you're going to have a week to catch up on some of the older shows that we have out there. Thanks for listening. That's all for now.